Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about antepartum hemorrhage. So what we wanted to discuss today, the definition and the epidemiology and the etiology of antepartum hemorrhage, which is a bleeding late in pregnancy or in the second half of pregnancy. Also, the important causes of antepartum hemorrhage, which is the placenta previa and the placental abruption and Vasa previa. As you see in this picture, the most important causes of antepartum hemorrhage is placenta previa, as in this picture, in which the placenta is implanted in the lower uterine segment. This abnormal site of implantation causes bleeding. So this is the placenta previa. The other picture here, the placenta is implanted in normal site high up in the uterus, but prematurely separated, resulting in bleeding and retroplacental hematoma. This is called the placental abruption or accidental hemorrhage. Okay. The third picture here is the Vasa previa. Here is the filamentous cord insertion in the placenta with fetal blood vessels passing through the placental membrane under the presenting part. And this fetal vessel, if ruptured due to rupture of membrane, will cause bleeding, and this bleeding will be of fetal origin, and they may cause fetal death within short time. Okay, so this is the most important causes. We can summarize again: the placenta previa in this picture, the placental abruption here, and the Vasa previa here. So what is the definition of antepartum hemorrhage? It is the bleeding from or in to the genital tract occurring from 24 weeks gestational age and the period to the birth of the baby. And you will find some definitions starting from 20 weeks up to the birth of the baby. Why? Because this is the gestational age of medical legal viability, and it is in USA it is 20 weeks, in UK it is 24, in Egypt it is 28. So as regard in UK it is 24, in USA it is 20 weeks. So if you read this definition with different gestational age, so you can understand now what is the difference. Okay. Let us know some terminologies about bleeding, how to have an expressions for bleeding, maybe spotting, this is streaking or just the blood spotting. The patient noted this spotting on underwear or sanitary protection, or the bleeding may be minor hemorrhage when the blood loss less than 50 milli, or major hemorrhage if the blood loss from 50 to 1000 milli with no signs of clinical shock. Or the bleeding may be massive hemorrhage when the blood loss is more than 1000 milli and there is signs of clinical shock. Antepartum hemorrhage accounts for 3 to 5% of cases during pregnancy and is a leading cause of perinatal and maternal mortality worldwide, especially in developing countries. Up to 1/5 of very preterm babies are born in association with antepartum hemorrhage. And you can imagine in developing countries there is 30% of maternal deaths caused by antepartum hemorrhage. And what is very important and surprising for you is that 50% of these causes can be avoided. So we should do care for any pregnant woman in developing countries to avoid death from bleeding as antepartum hemorrhage. What is the etiology of antepartum hemorrhage? I can summarize it into these 4 groups: either obstetric causes or gynecologic causes or general causes or unexplained with no definite etiology. In unexplained one, there is no diagnosed cause. There is antepartum hemorrhage, but no identifiable cause. And this constitutes the majority, by the way. It is 40%. What about the obstetric causes? May be related to the placenta, like placenta previa, 1 in 200, and placental abruption, 1 in 100, Vasa previa, 1 in 2000 to 3000, or due to uterine rupture, less than 1% in scarred uterus, or due to excessive shock. Or maybe due to gynecologic causes, like vulvitis or varices in the vulva, or vaginal trauma or vaginitis, or cervical ectomy or polyp or neoplasm or cervicitis, or maybe due to general causes like inherited blood diseases. This is a picture of the placenta previa, the placenta implanted in the lower uterine segment, as you see. And clinically, there are 4 types. This is the placenta previa lateralis, the lower edge of the placenta within 30 mm from the internal os. This is the placenta previa marginalis, the lower edge of the placenta at the level reaching the internal os, but not covering it. This is the placenta previa incomplete centralis, or partial placenta previa, partially covering the internal os. This is the placenta previa complete centralis, completely covering the internal os. So, what is the definition of placenta previa? Placenta previa is partially or totally implanted placenta over the lower uterine segment. As you see in the picture, this is the placenta lower down, implanted in the lower uterine segment and partially covering the internal os. And this is by ultrasound. This is the cervical canal. This is the internal os, and this is the placenta covering the internal os. We can say this is complete centralis. What is very important linked to placenta previa is there may be filamentous insertion of the cord and the vasa previa, as in this picture, in association with placenta previa. Also, with placenta previa, there is risk of placental adhesion, what is called placenta accreta, increta, and percreta, as you see in this picture. This is the normal. There is attachment to the muscle wall of the uterus. Penetrating the muscle wall of the uterus becomes increta, reaching the peritoneal surface becomes pericreta. So it was found there is association between placenta accreta and placenta previa, and vasa previa and placenta previa. So you should understand this point very well. What about the epidemiology? 1 in 200 pregnancies has a placenta previa beyond 24 weeks gestation. It is more common in multipara, but you should know that if you did an ultrasound in the first half of pregnancy, you may diagnose many cases of low placental lying, reaching up to 50%. But this is not true. Placenta previa, you cannot judge that this is a placenta previa except after passing the 24 weeks gestational age and by follow-up by ultrasound. So the incidence is 1 in 200, okay, after 24 weeks gestational age. This is what is called placental migration. You can see it low-lying in the first half of the pregnancy, then during follow-up by ultrasound in second half you will find that high up. So this is because the lower uterine segment is enlarged, so the placenta looks like it is migrated up. What are the risk factors for placenta previa? Maybe maternal or fetal. Maternal, like previous scarring, uterine scarring, or previous cesarean section, or other scar due to uterine rupture or perforated IUD or myomectomy, or due to period D and C, or surgical evacuation for miscarriage, or due to endometritis or submucous fibroid, or advanced maternal age, or due to multiparity, or maybe previous history of placenta previa is very important also as a risk factor. Maternal anemia and smoking. What about the fetal risk factors, including multiple pregnancy, placenta membranacea, large placenta as with diabetes, with pregnancy, and Rh isomionization, and lastly, the delayed development of the chorion as a risk factor related to fetal causes. Okay, what is the mechanism of bleeding? During pregnancy and during delivery. During pregnancy, as you know, the lower uterine segment enlarge and stretch, but the placenta is inelastic, so it cannot stretch. That's why shearing action occurs, leading to inevitable separation and the tearing of some placental sinuses and the vaginal bleeding. That's why this is abnormal site for the placenta. The placenta normally implanted high up in the uterus, the upper half of the uterus, posterior, anterior, or frontal. But if it is in the lower uterine segment, the lower uterine segment going to be enlarged during pregnancy. So shearing movement will cause this separation. While during delivery, why bleeding occur? Because there is progressive effacement and the dilatation of the cervix together with downward pushing of the fetal membrane leads to separation and the bleeding. So this is the 4 types of placenta previa. We call the type 1 placenta lateralis and type 2 marginalis anterior as a minor degree, while type 3 incomplete centralis and type 4 complete centralis, and the type 2 posterior, also marginalis posterior, we call it major degree. But really this is an old classification. This is the old classification about the degrees of placenta previa. As I mentioned before, we have the 4 types. The type 1, the placental edge encroach within 30 millimeter from the internal os, while in type 2, the lower edge of the placenta reaches the internal os but not covering it, while in type 3, partially covering the internal os, while in type 4, covering completely the internal os. But this is a recent classification recommended by the Canadian Society of Obstetricians and Gynecologists 2020. This is a normal located placenta as you see in the picture. We have abnormal location for 2 types of placenta, low-lying placenta and placenta previa. What is the definition of low-lying placenta? Edge of the lower edge of the placenta located equal to or less than 20 millimeter from the cervical os. As in this picture, this is the internal os and this is the placenta. We look for the lower edge of the placenta by transvaginal ultrasound. If it lies within 20 millimeter from the internal os, we call it low-lying placenta. Okay? But if completely covering the internal os, as in this picture, we call it placenta previa. So this is the most recent classification, divided into 2 groups, low-lying placenta and placenta previa. What about the diagnosis? The diagnosis, characteristically, the symptoms is vaginal bleeding, which is painless, causeless, and recurrent. Okay? This is the main symptoms. However, may be associated with pain due to uterine contraction, but commonly it is painless. This is the exception. Also may be initiated by intercourse. And lastly, the patient may be presented during first attack of bleeding. Okay? But commonly it is painless, causeless, and recurrent. In general examination, the general condition of the patient is proportionate to the amount of blood loss. So, with more loss of blood, there is hypotension, rapid pulse, even shock, and severe recurrent bleeding. Also, you will find pallor as a sign of blood loss. During abdominal examination, the abdomen is lax. Fundal level is equal to the period of amenorrhea, unless there is twin pregnancy. Fetal parts are easily felt. Malpresentation and non-engagement are common in placenta previa. Fetal heart sound are usually normal. Rarely suprapubic fullness in the type 2 anterior placenta. Assessment by transvaginal ultrasound is recommended, as in this picture, in all cases where placenta previa or low-lying placenta is present or suspected by transabdominal ultrasound. So, the patient presented to you by antepartum hemorrhage, you take history, you did general abdominal examination, but you don't do BV examination because you may induce severe horrible bleeding by BV. But you can do abdominal ultrasound. If you are suspecting placenta previa, proceed to do TBS. It is safe. Don't worry about that. As in this picture, this is the cervical canal, this is the external os, this is the internal os, and this is the placenta covering the internal os by transvaginal sonography. Is there a rule for vaginal examination? It is not recommended. You should remember this very well. But only you can do it in the operative theater, what's called double setup. And you are preparing fresh blood, is already cross-matched, is present, and the patient in labor. So you wanted to examine the patient because maybe you can give her a chance for vaginal delivery because it is minor degree placenta previa, and you can give her a chance for vaginal. So you will examine her, but in the operative theater, and there is fresh blood available for transfusion if needed, and all logistics needed for cesarean section is available right now, because during BV severe bleeding may occur and you should do emergency cesarean section at the same moment. So it is not done except for certain ports, but BV generally is contraindicated in placenta previa. When you are doing the double setup in the operative theater and the patient in labor, you are trying to determine the amount of vaginal bleeding, relation of the placental edge to the internal os, degree of cervical dilatation and effacement, the condition of the membrane, intact or rupture, presentation of the fetus and the pelvic capacity. Okay, what is the important investigation is the ultrasound, abdominal and the transvaginal, and the even sometimes transperineal ultrasound. The other imaging technique is the MRI, but it is expensive and near experienced personnel to do it. And I'm not in need really for MRI because ultrasound is quite enough for me to diagnose placenta previa. What is the rule of obstetric ultrasound? Really clearly define the placental location and also the characteristic of the placental edge, including thickness, presence of marginal sinus, and the associated finding like subcentriate loop, cord insertion close to the cervix, any filamentous insertion of the cord, any Vasa previa. Okay. Fetal viability also should be assessed, and the size of the baby and the gross presentation, and also you can exclude multiple pregnancy and fetal anomalies. So ultrasound is very important and diagnostic tool for all causes really of antepartum hemorrhage, either placenta previa or placental abruption or Vasa previa. Okay, what is the complication of placenta previa, maternal and fetal? Maternal hemorrhage, which may be severe enough to cause shock and renal failure and Sheehan syndrome. Also preterm labor, malpresentation, and non-engagement of the head, uterine inertia, cord prolapse, and BROM, increased incidence of cesarean section, increased incidence of placenta accreta, air embolism, postpartum hemorrhage, retained placenta remnant, global sepsis, and subinvolution of the uterus. What about the fetal complication? Prematurity, malpresentation and malposition, leading to prolonged labor and traumatic delivery. Vasa Previa, development insertion of the cord associated with placenta previa, as I mentioned before, also increase perinatal mortality. How can you classify the amount of blood loss into mild, moderate, or severe? Mild if blood loss less than 15% of intravascular volume, no change of the vital signs, no postural tachycardia or hypotension. In the moderate blood loss, there is 15 to 30% of the intravascular volume is lost. There is postural tachycardia and hypotension. In severe blood loss, more than 30% of intravascular volume is lost, leading to tachycardia, weak pulse, hypotension, rapid respiration called the clump sweat, and shock, oliguria or anuria, persistent loss of fresh blood from the vagina. What is the treatment? According to the guidelines of Canadian Society of Obstetricians and Gynecologists, bed rest or reduced activity is not beneficial in women with placenta previa. And this will be surprising to obstetrician because many obstetricians advise patients with placenta previa to have a bed rest and reduce completely her activity. But this is not advised according to the Canadian guidelines, not to ask the patient for complete bed rest, maybe little limitation of her activity. Why? Because they think that complete bed rest is potentially harmful, maybe precipitating for DVT and thromboembolism and something like that. And but at the same time, you should advise the patient to avoid sexual intercourse or insertion of foreign body in the vagina, because any foreign body or sexual intercourse can cause severe vaginal bleeding. So she should avoid this. When deciding the location of delivery, consider ultrasound assessment of placental location, any risk factor, patient's history, and the logistic factors, including available resources at the delivery unit. So the hospital should be tertiary hospital with blood bank and all facilities available for neonatology and for operative theater, well equipped. Everything is prepared very well in the hospital because this is one of the important complications with pregnancy. In women with placenta previa or low-lying placenta and in the presence of risk factor or limited access to urgent obstetric care, consider in-hospital management, should be admitted to the hospital. Cervical cerclage can be considered in women with short cervical length, particularly in association with antepartum hemorrhage, but not as a prophylactic measure for all women with placenta previa. So I never use cervical cerclage as a prophylactic measure for antepartum hemorrhage due to placenta previa. But in case of short cervix, you can do cervical cerclage. You can give the patient corticosteroid to enhance lung maturity. Okay. The Glucolysis also can be given to the patient if there is uterine contraction, just only to give a time for corticosteroid to reach its maximum effect within 48 hours. What about the time of delivery? Which gestational age we terminate the pregnancy? Depending on, is it placenta previa or low-lying placenta? Well, is there any risk factors? What about the severity of the bleeding? Is there a severity of the bleeding that needs emergency interference? Is the patient in labor or not? This is the factors affecting my decision as regard the time of delivery. So the recommendation for a low-lying placenta, placental edge equal to or less than 10 millimeter from the cervical os, is to be delivered between 37 to 37 plus 60 days gestational age in presence of risk factors. And we will know now in the next slide what is the risk factors. Or you can terminate pregnancy at 38 weeks or 38 weeks plus 6 days gestation in absence of risk factors. This is as regard for low-lying placenta equal to or less than 10 millimeter from cervical os. What about placenta previa? You can terminate pregnancy at 36 weeks up to 36 weeks plus 6 days gestational age in presence of risk factors. Or you can prolong the pregnancy up to 37 weeks to 37 weeks plus 6 days gestation in absence of risk factors. So what are the risk factors affecting my decision? First, history of antepartum hemorrhage. First episode before 29 weeks or recurrent episodes equal to or more than 3. The second risk factor is thick placental edge covering or close to the cervical os. The third risk factor is short cervical length, less than 3 cm with placenta previa, or less than 2 cm with low-lying placenta. The fourth risk factor is a previous cesarean delivery. Is there a trial of labor in placenta previa? Yes. It is recommended in women with low-lying placenta, this is a minor degree, where the placental edge is 11 to 20 millimeter from the cervical os, and it can be considered in a carefully selected woman where the placental edge is equal to or less than 10 millimeter from the cervical os. Okay? But of course, there is no other medical or obstetric contraindication for vaginal delivery. Okay? Which is better, general or regional anesthesia? Regional anesthesia is safe and adequate as a first-line anesthetic approach for the peripartum management of patients with placenta previa or low-lying placenta. Let us go to the placental abruption. As you see in this picture, the placenta is normally implanted, situated in normal side, but prematurely separated. So there is retroplacental hematoma here because separation happened. So what is the definition of placental abruption or accidental hemorrhage, the old name? It's the early separation of normally situated placenta from the lining of the uterus in a viable fetus, 24 weeks gestation age, before the completion of second stage of labor. Okay? As you see in this picture, this is the placenta, and this is the separation, this is the blood collected behind the placenta. What about the epidemiology? 1 in 100 pregnancies beyond the 24 weeks gestational age. Majority of placental abruption occur before 37 weeks gestation. It is a leading cause of maternal morbidity and perinatal mortality. It's very important, really. In many countries, the rate of placental abruption has been increasing even with improved obstetrical care and monitoring techniques. This suggests a multifactorial etiology that is not well understood. And you should know that the commonest pathologic causes of antepartum hemorrhage is placental abruption. But this is the commonest pathologic, okay? But the commonest overall is unidentifiable cause because it constitutes 40%. What about the risk factor for placental abruption? Maybe chronic hypertension or preeclampsia, very common with hypertension and preeclampsia, multiparity, previous abruption, short umbilical cord, preterm premature rupture of membrane, sudden decompression of an over-descended uterus as in cases with polyhydramnios, thrombophilia, antiphospholipid syndrome, blunt trauma to the abdomen or motor car accident, tobacco, cocaine, or methamphetamine use, unexplained elevated maternal alpha fetoprotein level, uterine fibroid, all these are risk factors for placental abruption. What is the pathophysiology? Look to this picture, please. First, there is a spasm of vessels in the uteroplacental bed, what's called the pseudospiral artery, leads to anoxia, which causes endothelial damage and rupture of the vessel and the hemorrhage at the level of the deciduoepitheliosis. This blood collected separate the uterine wall from the placenta. Okay? Okay. If the blood is retained behind the placenta and they can't pass away to the outside, it is called concealed hemorrhage. And you will find by ultrasound retroplacental hematoma and the patient has no vaginal bleeding. Or if the placenta separated at the margin, there is bleeding coming outside the cervical canal, is called the revealed bleeding. So concealed, the blood retained inside, and this is the more dangerous. Revealed, the bleeding come outside. And there is another type which is the commonest, is the mixed type. Partially retain the blood behind the placenta and another amount of blood coming outside, so it is mixed between revealed and concealed, and this is the commonest one. Of course, when there is damage of this vessel and occurrence of hematoma and separation of the placenta from the uterine wall, the placental circulation is affected, and as you know, the placenta is a source of nutrient and oxygen to the baby. So up to a certain level, the baby cannot tolerate and this fetal demise will occur. It is said that if 50% of the placenta is separated or more, sure the baby will die. Okay. What about the histopathology? Once the placenta delivered, the presence of retroplacental clot is almost always seen. There may be evidence of blood extravasation in the myometrium, resulting in purple discolorization of the serosa of the uterus, what is called covillary uterus. This is a dangerous one. Make the uterine wall pathologic. The blood leak in between the muscle layers of the uterus till reaching the serosal covering, making the uterus pathologic and atonic, and sometimes may need hysterectomy because of this. So we have clinical types, as I mentioned before: revealed hemorrhage, bleeding to the outside; concealed hemorrhage, the bleeding retained inside retroplacental; or mixed type, both of them vaginal bleeding and the retained blood inside. This is the commonest one. And this is a picture of concealed, and this is a picture of revealed one, and you see vaginal bleeding. What is the classification of placental abruption? Really, we have 4 classes: class 0, 1, 2, 3. 0, asymptomatic one, discovery of blood clot on the maternal side of the delivered placenta, discovered accidentally after delivery. Diagnosis is made retrospectively. You delivered the lady and they delivered the placenta, then you found a small blood clot, so discovered retrospectively. Class 1, mild type. No signs of vaginal bleeding or small amount of vaginal bleeding. Slight uterine tenderness. Maternal blood pressure and the heart rate is normal. No signs of fetal distress. So no problem also as regard the mild type class 1. Moderate type class 2, no signs of vaginal bleeding to moderate amount of vaginal bleeding. Significant uterine tenderness with tetanic contraction. Change in the vital signs, tachycardia, orthostatic changes in the blood pressure. Evidence of fetal distress may be found. Clotting profile alteration and hypofibrinogenemia. So there is risk. Class 3, which is the severest form, no signs of vaginal bleeding or heavy vaginal bleeding. Tetanic uterus, board-like consistency on palpation. Maternal shock, clotting profile alteration, and hyperfibrinogenemia and coagulopathy, and the fetal demise. So, placental abruption can be complete or partial as regard the placental separation, or maybe marginal or central. Okay, maybe marginal, the separation at the edge, or central at the center of the placenta. Maybe partial or complete. Classification of 0 and 1 is usually associated with partial and marginal separation. Classification of 2 and 3 is associated with complete or central separation. Of course, the concealed or mixed placental abruption is the most dangerous one than the revealed. Diagnosis from history, examination, and investigations. You should take a full history from the patient. Ask her about the prenatal course, especially the placental location on period sonograph. If there is history of placental abruption in previous pregnancies, you should ask her about this also. History of medical disease like hypertension, preeclampsia, or other risk factors. Exploring the woman's behavior, especially whether she smokes, uses cocaine, is a critical component of history. Asking about potential trauma, especially in the abdominal area. What is the clinical presentation of placental abruption from symptoms and signs? As regards the concealed placental abruption, sudden severe abdominal pain followed by fainting, symptoms of preeclampsia if present, signs, shock and the collapse in severe cases, not proportional to the amount of vaginal bleeding, pulse is rapid and weak, subnormal temperature and low blood pressure, and maybe signs of preeclampsia present. While revealed symptoms, the main complaint is vaginal bleeding, history of the cause or risk factor like external trauma, signs, the general examination show vital signs are proportionate to amount of bleeding. While in concealed one, it is not proportionate. Why? Because the bleeding in concealed type is retained inside the uterus. And the shock can be caused by the amount of the blood which is large and retained inside the uterus, and also due to over-distension of the uterus. Okay, in revealed type, also there may be signs of preeclampsia. What about abdominal examination in concealed? The abdomen is rigid, board-like, tender, larger than the period of amenorrhea because of retained hematoma, which may be large in size. Hard and tender abdomen, fetal parts are difficult to palpate, and the fetal heart sound show distress or even absent, maybe fetal demise. Local examination, there is no vaginal bleeding, maybe in completely concealed type, or in mixed type there is bleeding. While in revealed, the abdomen is lax, similar to that of placenta previa, nearly to some extent. The uterus is neither hard nor tender. Fetal parts are easily palpated, and fetal heart sound can be heard, except if there is fetal demise or there is distress. You can diagnose the distress because of bleeding. Local examination, vaginal bleeding which is dark or fresh, usually not severe. If cervix is dilated, the placenta is not filled. Investigation by ultrasound, as I mentioned before, as you see in this picture, this is the head, this is the placenta, and this is the retroplacental hematoma. This is the placental abruption, separation of the placenta and formation of hematoma behind the placenta. So, ultrasound is important to confirm the diagnosis, also evaluate the fetal viability, the growth of the baby, and position and the presentation of the baby. Lab investigation is very important really. CBC, renal function, coagulation profile, and DIC profile, fibrinogen, partial thromboplastin, activated partial thromboplastin time, prothrombin time. Other investigations may be needed related to the underlying medical disease like preeclampsia. What is the differential diagnosis? Really, we wanted to differentiate between placental abruption and placenta previa. Also, placental abruption and uterine rupture, because uterine rupture also is one of the causes of antepartum hemorrhage. But we will concentrate here with the placenta previa. The onset of symptoms is sudden and intense for placental abruption, but quiet and insidious for placenta previa. Bleeding may be visible or concealed with placental abruption and is external and visible with placenta previa. What about degree of anemia or shock? Is greater than the visible blood loss in placental abruption and is equal to the blood loss in the placenta previa, because in the placenta previa there is no retained blood inside the uterus. Pain is acute in placental abruption and absent in placenta previa. You remember when we said in placenta previa it is painless, but pain is acute in placenta abruption. The uterine tone is firm and board-like in placental abruption and is soft and relaxed in placenta previa. What is the complication of placental abruption? Maternal and fetal. Maternal include shock, renal failure, covillary uterus, ruptured uterus, coagulopathy, postpartum hemorrhage, transfusion-associated complication, hysterectomy, berberal sepsis, maternal death, fetal complication including fetal demise, fetal asphyxia, prematurity. What is the treatment? Treatment should be at hospital, following arrival to the hospital, 2 wide bore cannula and 2 intravenous line, and supplementation of oxygen, and continuous maternal and fetal monitoring is very important. While you are taking history and do physical examination, and insert Foley's catheter and measure the urine output. Ask for lab investigation, as we mentioned before, CBC, blood group, cross-matched blood, and RH factor, coagulation profile, the renal function test, ultrasonography to confirm the diagnosis and to localize the site of the placenta and the signs of separation and fetal viability. So what about treatment? As regard class 1 or mild placenta abruption and no signs of maternal or fetal distress and pregnancy less than 37 weeks, so the baby is still premature, may be managed conservatively, okay, in the hospital under observation. Patients are usually admitted in the obstetric unit for close monitoring of maternal and fetal status. Continue maternal fetal monitoring until there is change in the condition. Any problem happen or complication, you should do emergency cesarean section for delivery or terminate pregnancy if the baby reach maturity by vaginal delivery or cesarean section. Woman is classified with, if classified class 2 or 3, this is the moderate and severe classes, and the fetus is viable and alive, delivery is necessary. Because of the hypertonic contraction, vaginal birth may occur rapidly. Given the potential for coagulopathy, vaginal birth presents less risk to the mother. Okay, so vaginal delivery, if can be done, is much better than to do cesarean section. But at the same moment, don't take long journey in vaginal delivery. So you should follow the rules at the partogram, and delivery should be easy within reasonable time, because long journey may precipitate complication to the mother or fetus. Okay, so you should be careful about this. You should do artificial rupture of membrane, and it's very beneficial really, and maybe can use oxytocin infusion if there is no efficient uterine contraction. But if there is efficient uterine contraction, it is well and good. Why artificial rupture of membrane? There is many benefits from artificial rupture of membrane, really. Artificial rupture of membrane decrease intrauterine pressure. Also decrease passage of thromboplastin into circulation, which may cause the IC. So decrease passage of thromboplastin into circulation. Avoid amniotic fluid embolism. Avoid amniotic fluid embolism. Decrease uterine distension. And when I decrease uterine distension, I decrease the reflex renal artery spasm, which is injurious to the kidney. So, amniotic membrane rupture is very important. Also, artificial rupture of membrane will stimulate uterine contraction and relieve pain and improve shock. If there are signs of fetal distress at any time, an emergency cesarean birth is necessary to protect the fetus. During the surgical procedure, careful management of fluids and circulatory volume is important. Post-operative, the patient need to be monitored for postpartum hemorrhage. She is liable for atonic postpartum hemorrhage, very important, and also for bleeding tendency due to coagulopathy. Remember this very well. Remember, if the patient is Rh negative and her husband Rh positive, if she is not sensitized, she is in need for anti-D immunoglobulin, but it is preferred to do Clever-Betic test. Why you do Clever-Betic test? Because I wanted to know the amount of maternal blood, amount of the fetal blood passed to the maternal circulation to give the patient the appropriate dose of anti-D immunoglobulin. Okay? So, we do this test to know the proper dose of Rh immunoglobulin to prevent isoimmunization. A neonatal team needs to be present, of course, in the delivery room to receive and manage the infant. In case of fetus is premature, I need neonatal ICU. What about one of the important causes also of antepartum hemorrhage, although it is rare, which is the Vasa Previa. Vasa Previa occurs when the fetal vessel runs through the free placental membranes, as I mentioned before. The fetal vessel runs here as inflammatory incision to the placenta below the presenting part. So it is liable for rupture. If membrane is ruptured, this fetal vessel liable for rupture, and the hemorrhage here is of fetal origin. You should remember that. Unprotected by placental tissue, this vessel or Wharton jelly of the umbilical cord, Vasa Previa is likely to rupture in active labor or when amniotomy is performed to induce or augment labor, in particular when located near or over surface under the fetal presenting part, as in this picture. Vasa Previa is uncommon in general population, the prevalence ranging between 1 in 1,200 up to 1 in 5,000 pregnancy. Okay, so it is rare, although this condition may have been underreported. Yes. Vasa Previa has two types, type 1 and type 2, and please look to this picture. Type 1, this is the type 1, and this is the type 2. The upper one is type 1. Here the vessel is connected to the filamentous umbilical cord. This is the umbilical cord, and this is the filamentous insertion to the placenta. This is the placenta. This is the type 1. Okay? Is connected, the fetal vessel connected to the filamentous umbilical cord. Type 2, here, when the fetal vessel connect the placenta with subcentriate or accessory loop. This is the fetal vessel connecting the placenta with subcentriate loop. This is accessory loop of placenta here. So this fetal vessel connects the placenta to this subcentriate loop and lie below the presenting part here, so liable for rupture during labor, during dilatation of the cervix, during rupture of membrane. This is type 2. You understand now type 1 and the type 2. The classic presentation of Vasa Previa is painless vaginal bleeding, so it is antepartum hemorrhage also. But here, the bleeding of fetal origin and may cause fetal demise within few minutes. Rupture of membrane and fetal bradycardia. So the patient will present with painless vaginal bleeding, rupture of membrane, and the fetal bradycardia or fetal death. Vasa Previa may be diagnosed during early labor by vaginal examination detecting pulsating fetal vessel inside the internal os, or by the presence of dark red vaginal bleeding and acute fetal compromise after spontaneous or artificial rupture of membrane. Fetal mortality rate in this situation is at least 60% despite urgent cesarean section. Even you are doing emergency cesarean section, the mortality for the baby reach up to 60%. Imagine. So that's why we should discover these cases with Vasa Previa before complication, before the vessel is ruptured, before the patient in labor. So to plan for elective cesarean section and do not expose the baby for this fetal hemorrhage. However, improved survival rate over 95% have been reported where the diagnosis has been made antenatally by ultrasound, followed by planned cesarean section, which is the elective cesarean section as I mentioned before. What is the method of diagnosis? If you remember today, we diagnosed the placenta previa with ultrasound, accidental hemorrhage or placental abruption with ultrasound, also Vasa previa with transvaginal ultrasonography, as in this picture. This is the umbilical cord, the cord here, and this is the placenta, and this is the umbilical cord. Okay, this is the fetal vessel. Or I can use also the color Doppler, as in this picture. This is the Vasa previa, can be seen clearly with color Doppler also. The fetal heart rate pattern commonly sinusoidal and is usually non-reassuring. What is the treatment? Prenatal monitoring to detect cord compression. At most center, non-stress test is done twice per week, beginning at 28 to 30 weeks. The purpose is to detect compression of the umbilical cord. Then you are in need to admit the patient to the hospital at the gestational age between 30 to 32 weeks. Then do continuous fetal monitoring or use non-stress every 6 to 8 hours all the time the patient admitted to the hospital. Don't forget to give the patient corticosteroid to enhance fetal lung maturity. Then you can do elective cesarean section between 34 to 35 or 34 to 37. There is controversy about this. Okay, this is as regard the planned or elective cesarean delivery. But you may need emergency cesarean delivery at any time if premature rupture of membrane occur, or vaginal bleeding occur, or fetal status with non-stress is non-reassuring. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.